to mix it up. So Better Hearts, Better Cities is out of a response actually to what we've heard earlier today on the SDGs, the need for integration, and on these global goals really realize local action. And for us at the Novartis Foundation, that included looking at a multi-sector, multidisciplinary approach on how to tackle hypertension and cardiovascular disease in low-income urban populations. And this is also based on a model in which we wanted to use and develop for other non-communicable diseases. We've already heard from David on the non-communicable disease burden, particularly in diabetes, that can sum up to the size of a country. I just want to maybe reiterate also for hypertension, the deaths actually each year total 10 million, and that is in a sense a city. And so just to highlight the importance, and in our work with Better Hearts, Better Cities, when you look at non-communicable diseases, where 75% of all global NCD deaths occur in low middle income countries, it was very important for us to bring our initiative to 3 cities, in Ulaanbaatar, Mongolia, in Senegal, in Dakar, and in São Paulo, Brazil. As I mentioned, we were looking at a multi-sector, multidisciplinary approach, and this was really based on a collective impact model, leveraging the expertise that the Novartis Foundation already has in healthcare system strengthening, based on the expertise from Novartis as a company in cardiovascular disease, and leveraging other partners in a holistic approach from digital and technology with Intel, our partners there, to CDC, and our NGOs like PATH and IntraHealth, and the food agriculture sector with Syngenta Foundation, just to name a few, alongside some local organizations. Our initiative was really based on the principles of people-centeredness. So I resonate very well with what Remy was discussing on PPPs and the extra P on people, and really based on what we already heard, not just pilots and closed systems, but rather in a city which is dynamic and in an open system where we can test and design for scale. And so, as I mentioned, the burden and the cities that we chose are geographically spread. This was really to have representation. And in my discussion, I, based on kind of the recommendation to kind of deep dive a little bit more in one, to give you a reality and sense of what has been happening in the city in Ulaanbaatar, but I'll also highlight some examples from our other 2. And just as a backdrop then, in terms of vulnerability and also kind of populations, in Ulaanbaatar, which is the capital city of Mongolia, half of the population of the country live there. However, 60% live in informal settlements. And so those already have disparities on its own. And what was quite shocking, actually, as a fact, as we chose these cities, which was based both on health burden, local buy-in, and also ease of working through the World Bank's ease of working index, was those who were suffering from cardiovascular disease and deaths were primarily those already in their 30s, and that really has a big economic and social burden. And just as a last note, Mongolia actually has 4 times the average mortality rate of the global average from stroke, of which 70% is based from hypertension. And so the Better Hearts, Better Cities focused on several strategies, and I would say it included biomedical, which is one layer that David had mentioned. But also, we also, based on our experience, but we also built and partnered with others to really tackle the social and cultural social determinants as well. And so some of the 5 pillars that I'll bring examples on, and the key pillars that we really found is we really need strong local ownership for the multi-stakeholder partnerships. We had to develop a culture of improvement, for quality improvement for healthcare and health. And that really led then to thinking about how to improve the health system performance. And more, I think, as it resonates here, we bring care closer to where people work, play, and live. And through these and the generation of data and evidence, we're able to influence policies, both within health, but also as it got outside of health. And so in our first part on local ownership and multi-stakeholder partnerships, I want to highlight the multitude of partners that are here. And this is really built around how we started, is addressing local needs. And so instead of the typical way of the foundation maybe issuing an RFP, we really just convene partners on what the priorities were, really on the model, I guess, on collaborative engagement that Anna spoke to this morning, and distilling those priorities and asking for people, both leveraging our platform, for others to take part. In terms of improving a culture of quality improvement, it was very interesting because it was government-led and we brought partners around. In Dakar, for example, we were asked then to pull together a national plan for cardiometabolic diseases, and also really understanding the power of digital technology and digital health to transform. And so these were kind of the policies already that got set out to really lay the grounds on how we were to implement. We did a analysis on the situation, and in many places we actually saw maybe people were not aware, or if they were aware, got screened but weren't diagnosed. And that was definitely the case in Dakar, where I don't think we saw the rule of halves actually. And in Mongolia, where we saw a high screening rate at 80%, initially only 4.9% were actually diagnosed. And so how do we actually expand access and screening is really about bringing it down to the communities, and we got community representatives, patient societies to advocate, to learn, to educate peer-to-peer, but also task shift care down to the community through community health workers and sometimes even into the storefronts. We also, as we used non-traditional actors for care, we had to develop ways in which to standardize approach that was simple, easy to follow, and that included standardized algorithms, but also how do we link that, if it goes down to the community, through registries and digital databases that both empowered patients to know their and take ownership of their health, but also in terms of quality management. And this really led to then some system performance improvements. In Mongolia, we already had which was paper-based at that time actually. There was a clear need with too many fragmented silos on different registries and et cetera, that we asked the government again, a local prioritization, what were the things that they were not able to take on the risk to kind of develop or have the resources. And so part of that was a digital registry in which we used for primary care. and not just for hypertension. And through those efforts, we linked it up with prescription systems, with the pharmacy, et cetera, because we did find out, on adherence levels, also people were not refilling, or even when patients were going to the pharmacies, which were privatized, maybe actually a switching of medications or lower quality. And so through the system, we were able to improve the performance of the healthcare system. And with the data that, is quite simple in just collection, we see the power to transform in terms of management and really optimize care. I think this is more relevant now to the frameworks that we heard, including from David, on terms of how the physical, social, and resource environment play into urban health and disparities that people experience. And we saw an uptake and a call from companies with eagerness to engage with our program through partners, where workplaces wanted the health and well-being of their employees, of course, as if the top killer among 30-year-olds is already stroke. And we saw also the uptake on the education institutions and also the ministries of education really wanting to provide nutritional value and healthy behaviors already at a young age, including physical activity in low resource settings in which we've supported. And we saw the power of advocacy and with champions like Corinthians football team in São Paulo, who really mobilized the power of their platform to motivate others to engage. And so it's not listed here, but we in São Paulo, they've organized actually in a very local context also samba kind of festivals and different things. In Mongolia, it was more around just healthy eating, as and awareness on food as they were the greatest intake of salt at 11 grams per day versus the recommended 5. And so these things are adding up. And we really do see all of this adding up. And I think even though it was traditionally first starting as a biomedical basis in which we really have grounding, it really went into the food and nutrition space, where there's a proposal at the moment for trans fat and salt reduction and a ban on that for processed foods. We saw the tobacco tax pass as both respiratory diseases and air pollution were being addressed in the city, Mongolia being quite high in particulate matter. And through these taxes, we also see the recognition of our healthcare facilities, understanding the need for investing back, and so we saw the financial support for primary care institutions increase by 300%. And of course, what's really important is that it has an improvement in patient lives and people's lives, and we see that actually, the data we're still reading out, but I'm very happy to showcase that over the time that we started in 2017 to today, we're reaching 80% screened. We're diagnosing a significant portion of that, 80% of those who are expected hypertensives, and 70% are on treatment. And compared to the baseline, which unfortunately was 6% control at that time, we're breaking the rule of halves by reaching 77%. And looking at the sustainability, while this is a young program, I'd like to just kind of showcase the power of local mobilization and local ownership, in which we really started in Mongolia with only 25 out of the 142 clinics in Ulaanbaatar, and tested and refined the initiative. The next year, we really rolled out to the whole city. And now, this year, we're rolling to the whole country. And it's through this motivation that and our tools that are showcasing results that World Bank is also investing also in parallel to reinforce the country's digital health system, investment into the catalyzed digital health platform that we created together. Thank you.
Thank you very much.